the first presenter, David Mabirizi, to present to us on national implementation of the validated HIV testing eligibility screening tool and expansion of index testing to improve identification of children and adolescents living with HIV in Uganda in 2021. Welcome, David. Stand here to see your slides. Okay, it's fine. Whenever you okay.
Thank you. Good afternoon, everyone. After that wonderful debate, I request you to listen to this wonderful presentation too. It is evident that we still have a challenge getting children on treatment. And we need to, in order to achieve 95% of the children started on treatment and also successfully suppressed. But we start with testing. And it is getting harder and harder to identify children living with HIV. It is with pleasure that I present the national implementation of the validated HIV screening tool and expansion of index testing to improve identification of children and adolescents living with HIV in Uganda. I'm presenting on behalf of Dr. Jamali Bajunga and the team that worked hard to ensure that this tool did not end with a validation or a pilot, but resulted into a successful national rollout. As a background, CRS implemented the faith-based action for scaling up testing and treatment for children FASTER project from March 2019 to June 2022. The project mobilized stakeholders from government, civil society, and faith-based organizations to catalyze progress towards closing the gap of testing and treatment for children and adolescents across 4 countries: Nigeria, Tanzania, Uganda, and Zambia. Uganda had over 35,000 children that were in need of ART and had not been identified, and some are yet to be identified. Children and adolescents living with HIV are less likely to be aware of their HIV status in Uganda. Only 68% of children less than 10 years and 57% of children 10 to 19 are aware of their HIV positive status, and that was in 2020. This is compared to adults of whom 93% living with HIV know their HIV status. The low HIV prevalence among children typically means more testing is needed to identify one new HIV positive child. Facing this challenge, Uganda decided to use and implement a tool, a risk screening tool. The validated screening tool, HRAT, was adopted into Uganda's national HIV testing guidelines in April 2020 and has a sensitivity of 87.8%. It screens in children for HIV testing if maternal status was reported HIV positive, or if the child has a yes on 2 or more items on the screening tool, including sick in the past 3 months, sick in the last 3 months, recurring skin problems, not growing well, ever had TB, or lost weight in the last few months. Take note that the top blue items were adopted from the Zimbabwe HIV risk assessment tool. Methods. The analysis describes changes in pediatric testing and case identification pre and post implementation of the HIV risk screening tool. We analyzed the PEPFAR monitoring, evaluation, and reporting, MER, HIV testing data across all testing modalities for all 3,300 PEPFAR-supported sites in Uganda. The pre-risk screening tool period was 2019 data, and the post-implementation period was 2021 data. The objective was to explore changes in overall outpatient and index testing case finding among children 1 to 14 years. Data for 2020 was excluded to allow for the policy change and also the pilot of the tool, and data for voluntary medical male circumcision was excluded too. The number needed to test to identify one child living with HIV was calculated as the number tested over the number positive. The FASTA supported intervention focused on 89 facilities, in addition to above site TA across PEPFAR implementing partners and the Ministry of Health. The screening tool was administered by clinical officers, nurses, doctors, counselors, and triage staff. HIV testing was decentralized from the laboratory to other entry points to reduce loss points and to increase screening coverage. Privacy was enhanced, and awareness of screening tool was achieved through continuous medical education and outpatient department health education series with patients in waiting areas. Results. Across testing modalities, Uganda identified more children living with HIV in 2021, the post-implementation period, despite restrictions and lockdowns due to COVID-19 pandemic. Uganda decreased pediatric HIV testing volumes by 13%, targeting pediatric HIV testing services to children with the highest risk. Across all PEPFAR-supported sites, pediatric HIV testing programs became more effective in identifying more children living with HIV and more efficient in lowering the number needed to test to identify one new child living with HIV from 55 to 47. In the outpatient departments, using the HIV risk screening tool, Uganda targeted HIV testing services to children with the highest risk. HIV diagnosis increased by 47% using a validated tool. More children were screened for HIV testing, and pediatric testing increased by 9%. In OPD, 40 children were tested to identify one child living with HIV in 2021 during the post-implementation period, in a way more efficient than pediatric HIV testing in the same setting, which requires 46 children tested to identify one child living with HIV. Index testing services increased by 90% in the post-implementation period, testing nearly 74,000 children across PEPFAR-supported sites in Uganda. Pediatric HIV diagnosis through index testing increased by 42%, identifying 1,600 children living with HIV in the post-implementation period. Index testing has proven to be a successful approach to identifying children living with HIV across all pediatric age bands, less than 5, 5 to 9, 10 to 14. Lessons learned. Regular support, supervision, and mentoring of health workers on the use of the tool improved use and documentation in the information systems. Assigning staff trained on the use of the tool to conduct screening or oversee screening improved coverage and reduced missed opportunities for HIV testing in OPD. There was an improvement in pediatric HIV testing effectiveness in terms of more children identified living with HIV in OPD, and an improvement in HIV testing efficiency in terms of increasing yield and decreasing number needed to test to identify one new child living with HIV. In conclusion, validated HIV risk screening tools and index testing can increase HIV testing and case identification among children with the highest risk, especially in high volume, low prevalence settings. The validated risk-based screening tool resulted in a reduction in the number needed to test, making OPD testing slightly more efficient than pediatric index testing in Uganda. It is therefore recommended that programs validate and increase the use of screening tools to improve HIV testing effectiveness and efficiency. As the last message, in this experience, national rollout of a validated pediatric HIV risk screening tool with high sensitivity and expanded pediatric index testing services identified more children living with HIV in Uganda, even during the COVID-19 pandemic and with fewer tests overall. I end this presentation with acknowledgement and appreciation to all contributors to this work: health facility staff, patients, Ministry of Health, Uganda, CDC, Uganda, CDC Atlanta, CRS, Ugandan CRS, USA, DOD, and USAID, Uganda. Thank you.
Thank you.